So thanks everyone for the opportunity to speak today. We're going to switch gears a little bit. I kind of wish I had heard Matt's talk earlier before I made my talk. So if I didn't follow all of his pearls, you'll understand why. So my topic today is developing realistic and challenging simulation curricula. Let's see here. And I have no disclosures. And I'm going to stand over to the side of those so I can see my screen. So I think when you're thinking about developing realistic and challenging curricula, you have to ask yourself, what skills are you trying to teach? And that is usually divided between technical versus non-technical skills. And then more specifically, are you teaching technical skills to junior residents or to senior residents? So we'll take these kind of one at a time. First, with teaching technical skills to junior residents. And when you talk about realistic and challenging, a lot of times people start thinking about simulators and what the most cutting edge, greatest technology simulators are. And so I thought I would review kind of what's available as far as simulator technology. So it starts off with the most common, benchtop and laparoscopic trainers. This is what FLS is based upon, as well as the ACS, APDS Phase 1 core skills. There's obviously a lot of pros to this. They're generally very cost effective. They've been demonstrated to be able to assess junior residents on basic skills. But the truth is that they are lower fidelity, and sometimes it's hard to use these for more senior residents or for faculty. And so there are issues with realism. Next, you have live animal models, which actually are a great model. They're much more high fidelity. If you're using live animals, you have to deal with the issue of bleeding, which makes the whole situation more real. And oftentimes, you're working with a group of people on that one animal, so there are teamwork skills that you can practice. And this is the model for the American College of Surgeons ADAM course. The cons to using live animal models are that they are more expensive. There are obviously ethical concerns, and they can be structurally different depending on what animal you use compared to human anatomy. Cadavers, and especially fresh tissue, is kind of the gold standard for simulation work. This is accurate anatomic structures, obviously, and you can use pressurized systems and perfuse those cadavers with blood. This is the basis for the ACS ASSET course. But there are issues as well with cadavers in that they're very expensive, limited availability, and you need special people and special facilities in order to offer these. They can be resource intensive. Virtual reality simulators, this is the basis of the FES curriculum using the GI Mentor, as well as robotic curricula with the Da Vinci simulator. These have really come on the market. They help residents and trainees develop hand-eye coordination. A lot of them have full-on procedures that you're able to practice. It offers metrics right then and there on accuracy, et cetera. And these are pretty potentially, they can be high fidelity, and they are reusable, and many different trainees can use them. But again, they can have lack of force feedback. They can be expensive. And some models may have limited realism in the sense that just because they have a simulated lap chole doesn't mean it's like the actual operation. And then finally, there's a lot of new innovations and new technology on the market. Many of us know about kind of 3D models. There's now patient-specific 3D model simulators, as well as a lot of augmented reality technology. But these are also not accessible to everyone. They can be expensive. And studies, while the first 4 categories have shown a lot of merit in assessing residents, there are still many more studies that need to be done on all of these new technologies. So when everybody looks at all the different types of simulators and simulator technology on the market, a lot of times people want to pick one and they feel like they can build a curriculum around that simulator, and that's actually the wrong way to go about it. What you really want to do is take your simulator and put it into a strong, solid skills curriculum for your residents. So you want to make your simulator fit your curriculum and not your curriculum fit your simulator. And specifically, when you look at simulation-based training and technical skills acquisition, the most effective curricular design, as most of you in this room know, is proficiency-based or mastery learning, distributed training over time instead of a single massed session, deliberate practice, which is focused, repetitive practice of targeted skills until you reached pre-established metrics, as opposed to just random skills practice. And training to automaticity, or training until the demands on attention lessen over time for performing that particular skill. And I'm going to give everybody time to look at this comic, as Matt pointed out. And deliberate practice, as all of us know, accounts for the difference between masters, experts, and novices. And the truth is that the variety and the frequency of encounters that our residents are exposed to during their surgical residency is really not enough to yield true deliberate practice activities. So when you talk about deliberate practice, specifically in surgical education, you need to practice over a long period of time with ongoing efforts to maintain it. And so working on patients alone is not true deliberate practice. And that's where models and simulators can come in and provide for these deliberate practice opportunities with maximum efficacy with adequate practice time. And so I just wanted to go through a new curriculum that we rolled out this year at the MGH for technical skills training for our junior residents. And I think this is a pretty good effort of ours to be both realistic and challenging. And so I'll offer this up as a potential example of such simulation curricula. And so this is for our PGY 1 through 3 residents. And the curriculum is weekly and integrated within our Thursday morning surgery school. So it's mandatory and it's protected time for the residents. And we are using the ACS APDS surgical skills curriculum because you really don't need to reinvent the wheel. This is already there. And in fact, the newer version of the Phase 1 skills gives you a lot of kind of off-the-shelf advice and ways to make models, et cetera, so you can run this at your institution. We focused on the Phase 1 core surgical skills. And in preparation, we actually gave a needs assessment survey to our residents and faculty last year, where we found that our chief residents felt proficient in all of their skills, but they didn't feel that they gained proficiency in advanced laparoscopy and hand-sewn bowel anastomosis until their chief year. Our mid-level and junior residents felt that it was lack of operative exposure that prevented their attainment of proficiency, so they requested more exposure through cases in the OR as well as simulation. And they specifically wanted peer training in the skills lab, a more structured skills curriculum, as well as more patients on behalf of the attendings. And so our format is longitudinal. It runs 2 cycles throughout the year. Each month, that we focus on a new technical skill or set of skills, and residents receive an email with module information, a video link, and assessment forms. And then every week, they have small group sessions throughout the month, and then on the last week, they have a skills assessment or OSAT session. And so if you see here from July through January, these are the skills that we focused on each month, as well as the breakdown between PGY 1 through 3 years, like which residents were participating in which simulation sessions. And if you look here, we have a very strong faculty presence. Each skill is small groups, so small groups of maybe 9 to 12 residents. And we start out with like a chef's table where the attending will teach the skill, and then they break down into small groups. And if you see in the middle there, I don't know if I can find the laser pointer, here's Dr. Ratner teaching. This is hand-sewn bowel anastomosis. So you start with 9 to 12 residents, and they break down into groups of anywhere from 2 to 4 residents working with attendings. We also have a residents as teachers program. And as you can see here, many of our lab residents come back into the lab each week to help teach. So in each one of these photos, in addition to our surgical education fellows, our lab residents come back and they actually teach in small groups with the junior residents. I think one of the biggest improvements to our curriculum is more formalized assessment and feedback. And so we use OSATs, which is very apropos with Dr. Resnick's talk this morning. And so at the end, the last Thursday of every month, they get instructions on the skill that they're supposed to be performing. And we score them on the global rating scale as well as a task-specific checklist. So this occurs again on the last week of every month. It's mandatory for all categorical residents. Our faculty serve as the examiners. So if you're talking about challenging, I think that's pretty challenging where you don't want to look unprepared in front of your attendings. You cannot take an OSATs unless you've been present at a prior didactic session. And 1 week prior to your OSATs, the residents receive an email again with the assessment form so they know what they need to do, as well as a testing schedule. On the OSATs day, the residents gown and glove. So if you're talking about realism, we want to make it as realistic as possible. We also have them wear a GoPro that helps record their performance. They get a set amount of time to perform each task, and they receive no instruction from their attendings. And so the attendings are asked to just be kind of like a medical student assistant. And so if you ask the attending to hold suture or cut, they can do that, but they cannot give you any instruction, no matter how poorly you're performing. There's multiple simultaneous stations, and the residents rotate from one task to another. And the models that we use for our PGY 1 through 3 residents are the models that are on the ACS APDS curriculum. And so they're relatively cost-effective, and they work really well. And so this is the setup for biopsy. This is for suturing. Here's a happy model that's about to get an airway. And this is a porcine trachea that our residents are putting a surgical airway into. Hand-sewn bowel anastomosis, stapled bowel anastomosis, vascular anastomosis. So these are all examples. And then finally, at the completion of each task, these residents get immediate verbal feedback, and their feedback session is recorded as well through the GoPros. And so as you can see here, here's our attendings. Dr. Ratner's up there as well as our other attendings who are working with the residents one-on-one during these OSAT sessions. When they complete the OSATs, they get a report card that tells them how they performed, as well as how they performed compared to their cohort. And they also get, each resident has a skills portfolio, which has their uploaded assessment video, a recorded feedback session, their OSAT scores, and they can review this on their own time for self-guided learning. If you ask our residents after we rolled out this curriculum, they have, on surveys, they've responded that they feel these skills are relevant, they've been helpful to them, their confidence has been increased, it's actually helped their skills in clinical scenarios, and they feel that this is worth their while, even though they're missing time in the OR. And I think all of this points to the fact that it is realistic enough for them, and challenging enough as well. I mean, if you come to some of these OSAT sessions, it actually is almost like Olympic trials. It gets very tense in there. Now, if you're teaching technical skills to more senior residents, obviously you have to kind of change your strategy a little bit. Again, start with a strong curriculum. So the Phase 2 skills in the ACS APDS curriculum is already there and is something they can easily follow. But you may need to consider more advanced simulators. And so we do have a lot of our industry partners also offer some of these models, but there are laparoscopic colectomy trainer, ventral hernia trainer, lap cholecystectomy. And as you move into more of these advanced procedures and more senior residents, this may be a time that if you have access to VR simulators, this is for lap ventral hernia, and now there are immersive VR technologies as well if your institution happens to have access to that, and that's where you're performing these procedures, you put on these VR goggles, and you're actually immersed in an operating room environment. I think the key to a lot of this also is being creative, and so thinking outside the box about what your residents need and how to make models that are realistic and can simulate what they see in the operating room. And if you're feeling that you're not creative, then collaborate with people who are. And so we have simulation technologists who are just really great at making models. And an example is last year, we had a senior chief resident who felt that we needed to make a model to teach juniors how to tie deeply, but not just on like those Ethicon boards where there's a hook and you can use as much strength and tension as you want, but like for vessels. So if you're in vascular and you have a schnitt and it's down deep and you have to tie down to it so you don't avulse anything. And so we worked with our sim techs and they took a small sharps container and they put in all of these little vessel loops. And so you can see here you have to tie to this, or if you're practicing using your schnitts, here's a vessel, for example, down here where you have to schnitt, cut, and then tie down to it. But if you pull too hard, the vessel loop will pull out. Another example is we wanted to work on foregut procedures and lap Nissen fundoplication. And so one of our sim techs from a few years ago created this model where we took ex vivo porcine stomach, which is here. This is the two crura. And then she made the spleen and the liver balloons so that if you're suturing and you pop them, that would be something bad. And we put this into our laparoscopic box trainers. So just switching gears, for non-technical skills, it's a whole different strategy. We do a lot of work with interprofessional education at Mass General, and so some of the kind of tips and tricks for creating realistic and challenging curricula are divided into two main principles. So you want to create high-fidelity clinical scenarios when you're doing operating room team training, and you also want to create a socially realistic setting and team. And so in order to hit the high fidelity scenarios, you really want to engage an interdisciplinary core faculty that can help you develop scenarios that address nursing concerns, surgical concerns, scrub techs, anesthesiologists, et cetera. And you may want to consider hybrid simulation where the surgeons are working on something technically and anesthesiologists can be working on a mannequin that's having DSATs and tachycardia, and nurses can be opening up new instrument trays that may or may not be contaminated, so it's more realistic. With regards to the group of people that are in your simulations that are participating as your learners, each profession should have a significant and balanced role, just like it is in the operating room. And you want to maintain the usual social dynamics that exist between health professions. And so there's naturally in the operating room, whether you like it or not, there are difference in hierarchy, difference in status, difference in interdisciplinary dynamics. And so you want to kind of replicate that in your in any of your team training sessions. And one example here, I won't apologize for the slide. Hopefully you can see the photo well. But there's just a lot of people. This is a simulated cardiac surgery simulation that we ran, and we had perfusionists involved in our simulation as well. So it was as realistic as possible, and at any time there were like 10 to 15 people in that operating room, and it was loud, and it was noisy, and it was crazy, but I think that's what it's like in a cardiac surgery room all the time. Again, you want to be creative, and you want to collaborate with people who can work with you synergistically. And so this is an example. We collaborate with a group called the Center for Medical Simulation in Boston. And so these are pluots, which is a fruit that hopefully most of you know about because they're like the most delicious fruit ever. And someone that we worked with, Dan Raymer, created a bleeding pluot model. And what that meant was he took these pluots, and when you take the skin off of it, this is what a pluot looks like. And then if you take red Jell-O, this is what that looks like. And he dropped the pluot in the Jell-O and then hooked up little tubes that would run red food-colored liquid through. And so that was, for the longest time, our bleeding tumor model when we had surgical simulation. And after collaborating with some more engineers, we kind of advanced that model. And so this is that bleeding pluot that's no longer a pluot. And so now this is a bleeding kind of plastic model that we can drop into a pelvis, into a chest, into an abdomen, whatever you want. There are certain controls here that can be, you can control the model off an iPad. And then as you can see here in this video, it's actually quite realistic. And so the blood just keeps pouring out no matter how much pressure you put on it, just the blood keeps on flowing. I just want to run through a few other quick examples when we work with neurosurgeons. Again, all of these are pretty low cost. And so this is an example of, there's a flap, a bone flap on the skull. And there's that same similar bleeding model is in the brain here. And this is infected hardware. And so we just borrowed some hardware from the operating room, and then we created a little abscess cavity. And apparently online you can buy something that makes the fluid smell, and so it smells like pus. I don't know, I wasn't involved in that. That's where collaborating with more creative people is helpful. A vascular case, this is for our residents, and so this is just a Penrose drain that we ran fluid through, and so the residents had to work on a vascular anastomosis without letting the patient bleed out. And here we did an orthopedic model, and it just involves a lot of hardware. And so by putting all these kind of retractors on, it seems very realistic. And if you look more closely, Here is a pubic symphysis. Here's the bladder being retracted upwards. And we took that same bleeding model and put it in the pelvis. So in summary, I think if you want to develop realistic and challenging curricula, it depends on what you're teaching. For technical skills, always start out with the basics. You need a solid skills curriculum with formalized assessment and feedback. That in and of itself is challenging enough. And just realize that you have different needs for different learner groups. For non-technical skills, high fidelity clinical scenarios, so working with interdisciplinary faculty to create those is helpful. And make sure that in each of your scenarios, you have a realistic team that's working together, a realistic setting, and realistic social dynamics. Capitalize on the resources that are available to you. If you don't have a VR simulator, lap box trainers work just as well. And also be creative and collaborate with people in order to come up with new ideas for what your learners may need. Thank you.